All right. Hey, Facebook land. Welcome to another CalCare office hours. We're here, myself and my tech slash producer slash everything else, Paul. And we're here waiting for you guys to come and ask us questions. In the meantime, one thing I wanted to talk about today is how are you going to pay for it? I've been seeing that so much lately. How are you going to pay for it? 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 And not to rope in 9/11 into this, but because we celebrated the unfortunate 20th anniversary of 9/11, which is like, wow, I am gonna tell my age. I was actually in 8th grade. So don't judge me, Paul. I know you're gonna laugh at me, but I was in 8th grade on that day and, of course in class, but, one thing was September 12th, which is today. And if you remember the day after, like it was an eerie day. It was very eerie. And it was kind of a moment. And if you remember the day after, it was a brief moment where we were just American for a moment. Now, I know people watching will be like, well, I know, I'll get to that. But for a brief moment, we were actually a little unified. And here comes United We Stand and all that stuff. But I really wish that feeling would carry today when it comes to facing this pandemic, because we have lost so many people for this pandemic, due to this pandemic. And I can't even, if you think about it, we've lost 600 and something, I think close to 650,000. I don't have the exact number. Last time I checked, it was like 640,000. Americans, this is Americans here on, in America, our US soil, that we have lost to COVID-19. And, on September 11th, we lost, getting close to kind of 3,000, I think, people. But it was, of course, terrifyingly devastating events that occurred. And now I'm looking at it and I'm just like, well, if you look at the lives we lost on 9/11, it would be like, I don't know how many 9/11s happening to equal the death count that we've had for COVID. So I'm not kind of trying to compare. It was something that I realized. And I know it's totally different events. One's a pandemic, but both of these are kind of a war. It's just unfortunately that this time the assailant is microscopic, but we are at war. And another thing about war is that, there was no hesitation to go to war after 9/11. A few politicians, shout out to Barbara Lee, opposed and tried to get people to think logically, because I think she foresaw what we were heading towards, which was a destabilization of an entire region of the earth. But I think that, we were so united in defending ourselves against this terrible atrocity of an event that happened. And I just, there was no questions about funding. There was no questions about that. We were at war. We had to defend ourselves, And I say all of that to say this, is that we are still kind of at war, with this pandemic. It is a war and it's taking many, many lives. And so I just say, when we're going to pay for it, you're talking about the health of Americans, of people who are living here in our country, in our state. And you ask me how we're going to pay for it. I can't help but think about that time where there was no question about how we were going to pay for it. We were going to war. There was no question about repercussions. It was just gone. Here we go. And I just can't emphasize enough how, especially as an RN, I feel that we have been at war, but I don't get that same support. I don't feel that same, like united we stand, because it's obvious, that we're not. Everybody has an opinion. Everybody has a thought. Everybody, is bucking against the mandates or the vaccine. So I just want to put that out there because, everyone it was a somber day yesterday. And I just want to make people understand that we still are facing a big threat here. And it's just not in that way that happened 20 years ago. It's just microscopic, but it's way more deadly, unfortunately. So just keeping that in mind. I know I always start the day with my COVID soapbox. And so I just want to make sure that everyone is taking good care of themselves. for our elected officials. I really want the question about AB 1400 or CalCare to not be how are we going to pay for it. It is more so, how are we going to make this work? How can I, as the elected official, help make this work for the people, to get the people the care that they need? Because we know we wouldn't have lost so many lives if people would have had better access to care. So that is how we're going to pay for it. No, but we'll go in more to how we're going to pay for it. I just want to give a big shout out and a welcome to Dr. Bill. But yeah, you are tuning in to the, I don't know, number, CalCare office hours, which is a great venture and partnership between Healthcare for All Los Angeles and PNHP, nurses and doctors coming together to get you the care that you need, which is fantastic. And a whole bunch of other healthcare activists who know that this is the way. Mandalorian, it goes with our Star Wars theme, right? So let's talk about CalCare. What is it? You know, I know a lot of people tuning in. You guys tune in every week just to see me talk the same stuff, which I appreciate and I love you all. But for someone who might not be, you know, who's tuning in for the first time, which some people are, and I greatly appreciate that. You know, I want to discuss, well, what is CalCare? And so I'm going to go over what I like to call what is
Gina,
yeah.
Gina, can I just add something since you're on the theme, the 9/11 theme, and what, you know, not just how we're going to pay for it, because we're all paying for it either way, right? Whether we do something about these things or we don't, we're going to end up paying for it, you know, one way or the other. It's like when someone goes to emergency, if they have insurance or they don't have insurance, it gets paid for one way or the other, right? We all know that. So it's going to be paid for. Because that's what it means, you know, because somebody's got to do the work, someone's got to get paid for the work. So, so who's going to pay for it? But and you know the how, as you said. But I think one of the themes of 9/11, looking back 20 years, which seems incredible, is that we shouldn't be talking about a war on terrorism. We should be talking about a war on preventable deaths. You know, these are preventable deaths, preventable human lives lost and suffering. And we could prevent that with a system. What we're talking about here, CalCare, AB 1400, for California, the fifth largest economy in the world, we could prevent, you know, with COVID, 40% of all the deaths in California. So we need to declare war on preventing deaths due to public health emergencies like COVID and other public health emergencies. And that's what we're talking about here. How does California meet up to the standards of other states and nations around the world who outperform us in life expectancy, infant and maternal mortality? You know, we spent, what was it, $300 million a day in Afghanistan for 20 years since 9/11. $300 million a day, you know, trillions of dollars were spent in Afghanistan. You know, and what did we accomplish? Not much. You know, I think we actually provided healthcare for the people in Afghanistan where we didn't here. So that was a good thing, that one aspect of it. But we could be providing healthcare here for only $25 billion. We could vaccinate the entire world. Only $25 billion. Now, commonly spend.
Jeff Bezos could front that bill, right?
Yeah,
Jeff, are you going to do that? Are you fronting the bill for everyone, the whole world, to get vaccinated?
Yeah, that's fun. 25 billion. That's
just
nothing
25 billion. I think
for Bezos. Yeah, or Elon Musk or Bill Gates. Any one of them.
Just split it in thirds. Just take a third and vaccinate the world.
Vaccinate the world. Let's wipe out COVID right now. You know, any one of them could do that. Okay. So, that's all it takes. So I think, thank you, for bringing up the lesson of 9/11 and this war on terrorism, which now should be a war on preventable human suffering and death, which is what you're about to talk about for California. Thank you.
So yes, and as we, one thing about, I don't want to keep using war. We're not a war mongering group here. We don't do war. But one thing you do know about war or just getting anything accomplished is that you've got to have a strategy. And one of the strategies is to be motivated. And one thing that motivates me is knowing what CalCare covers, knowing that CalCare is California guaranteed healthcare for all, truly, because this is a solution to the broken healthcare system. We know it's broken. Everybody knows it's broken. When GoFundMe is considered technically like an insurer, then yes, the healthcare system is broken. And this guarantees healthcare as a human right in the state of California by providing comprehensive, high quality healthcare to all, emphasis on the all, just like Medicare for all would do nationally. So we're saying this is going to be universal coverage, everybody in, nobody out. So if you are a body, you are part of every, regardless of what your race, your sex, gender, country of origin, disability status, immigration status, marital status, income, you're going to get the care that you need regardless of the ability to pay. This is going to be a single public program, a single payer, single one payer, meaning I don't have to worry about the 100 and something health plans and programs in California that I have to wade through every day to get my patients the care that they need and to make sure that the hospitals and the doctors are reimbursed properly for it. A single payer program would streamline healthcare. It will be a publicly funded through progressive taxation, meaning that Bezos, since he's not, going to have the write-off of providing vaccines for the world, which that would be a great write-off. So if he really wants to do it, I think that would probably allow him to pay zero taxes. I would be okay with that. If you vaccinated the whole world and didn't pay taxes that year, okay, you did a really good thing. So I'll give you that. But next year you're paying taxes. Anyway, to cover all necessary care in California, this progressive taxation is going to help cover all the necessary care in California, eliminate billions in bloat and waste. And so that bloat and waste goes back to having to navigate a gazillion plans who want to make their own rules. They have to work within guidelines, yes, but they all have their own little nuances, and there's no way in hell I know all of them. And so you spend a lot of time just trying to get claims paid, get patients the care that they need timely. And that just takes up a lot of staff time that is unnecessary, so that eventually, of course, you have to pay those people. So there's more. And then patients going around having to go from one specialist to another specialist to another specialist, trying to get what maybe if they just would have been sent to a higher level specialist in the beginning, would have gotten the care that they need in that one, instead of having to spend all this extra money going in their network circles. And then so that, of course, if the California is saving billions, then of course that saves people thousands, on their healthcare costs. So we're talking fully comprehensive benefits. So we're not just saying, oh, well, we'll make sure everyone has the basic stuff. Like we'll cover your annual physical and we'll cover maybe your basic medications. No, we are not going to be some basic B words over here. So we're going to include medical, dental, hearing, vision, mental health, prescription drugs, long-term care, and more. I know people right now who have never had dental, hearing, or vision insurance. Their employers didn't provide it. They couldn't afford it. They've just never had that coverage. So that means that, who knows how often they've had their teeth checked, who knows how often their hearing is checked, their vision, because there's a lot of hearing loss. I mean, I grew up in a generation with really loud music. So yeah, I'm pretty sure we could use some hearing support right about now. Not to mention vision. I mean, we have been trapped in the virtual world for over a year now, almost 2 years, thanks to Zoom and this pandemic. And so all of this computer light has taken a hit on our vision. So how many of us have actually been able to go get our vision checked and then get the screenings that come with that? And so even with the current insurance that I have, I still spent about $350 on glasses and things like that, because the vision insurance truly is just like a discount card. It's not insurance. Anyway, so mental health, that's really important, especially right now. Prescription drugs, long-term care. So long-term care is not something that you think is covered like you would think it is. Medicare doesn't cover long-term care, for number one. Medi-Cal does if you have, are able to get it, but it's not as easy as you think to get Medi-Cal either. So, and then more coverage. So all decisions about care will be made between you and your doctors and nurses, not the insurance companies. Well, Gina, what does that mean? So when you need a procedure or something that's like not emergent, but you need to have it happen. So your doctor's office submits a request for authorization for this procedure for you to have, let's say, a knee replacement or something of that sort. And then the insurance company will review it, look at the records and everything, and determine whether or not you meet criteria for this procedure. The insurance company's doing that, not your doctor. Your doctor determined that you need a knee replacement. You saw the orthopedic surgeon and they said, yeah, that you have like zero cartilage and you're bone on bone, so you need to have a knee replacement done. And so the doctors have determined that, but the insurance company is the final say. So if the insurance company, for whatever reason, feels like you don't need it, well, guess what happens? Unless you're paying out of pocket, you ain't getting it. And we're sitting here in the offices or the hospitals like, so it goes back to that bloat and waste, because now someone like myself or the doctors are sitting here going back, trying to advocate for you to get this procedure, saying, well, why was it denied? And okay, we'll go and maybe we need to provide more documentation. Okay, so let's get more documentation. Let's send that off. And then we go back and we have to spend who knows how long on the phone on hold, trying to get to the right department again, because they never have direct lines to these people. And so, that goes back into that bloat and waste. And that is where we say all decisions between you and your doctors and nurses and not the insurance company. So that's what that means. Freedom to choose your care provider. Under CalCare, there will be no more in-network, out-of-network. You'll have the freedom to choose any doctor or hospital you like. That means that if you have your current primary doctor and you're not too fond of your current primary doctor, you can leave your primary doctor and go find another one and not have to worry about, is it in network? Is it not in network? If you know of a primary doctor that you feel like would meet your needs and maybe is culturally appropriate, for example, that's big. Culturally appropriate care is huge. Having someone who is, more involved with the culture and the community, it leads to higher compliance. It leads to just a better overall relationship and better health for that person when you have someone who is culturally appropriate with someone that may have a similar background of you, or if not, just really cool doctor, or nurse practitioner, but you should have the right to sit there and call them and say, are you taking new patients? Do you have availability in your schedule? Because that's still going to be a thing. And if they say yes, and you say, well, I would like to schedule an appointment. Okay, great. I have CalCare. Perfect. Come on in. And that's that. So, no more. Do you take Anthem? Are you in network with Anthem? Are you platinum tier for Anthem? Because I have to do platinum tier. If I do anything other than that, then I get charged more. I have to pay the higher copay. No more of that. We're talking free at the point of service. So no more copays, premiums, or deductibles. So you go to your doctor's office because you just found that new really cool doctor that you want to go see, and you show them your CalCare card, you get your new patient forms, and you go have a seat. That's that. No more, well, you have a $25 copay, so you have to go dig out $25 or whatever amount of money for your copay. No, you just get your new patient forms, because those aren't going away with CalCare. We still need the new patient forms. and then you go have a seat. And then, so just transition. Well, Gina, what's going to happen to all these people? Well, the good thing about this bill is that it has language for just transition, which means funding and programs to protect and support any displaced workers in the insurance industry. I know we're talking about a very big industry here, but because this bill is so comprehensive and was written not just from the sake of, okay, can we make money off of it? And is it going to get me elected? No, it was written with the people in mind. So we know that the employees of the insurance industry should not have to suffer because the heads of the insurance industry have taken it down a very dark road. So those people should be able to have a just transition, and that language is written right here into the bill. And then lastly, patient care based on patient need. No more financial incentives to avoid providing necessary care, including value-based payment models for providers. So when I say no more financial incentives to avoid providing necessary care, Gina, I heard that there are loopholes, or not loopholes, I'm sorry. I heard that there's already regulations to prevent that. You're absolutely right. But there's always a way around that. So when a financial incentive to avoid providing necessary care looks like this, it looks like, okay, well, you're at such and such hospital, maybe a small community hospital that was close to you, they can't accommodate your care. Or you need to see a higher level specialist because unfortunately, maybe you need something that needs that higher level. And your insurance company is like, well, we could send them there. It's really pricey. The rates are high. Could we just send them here first and see what they say? So that's financial incentive to avoid providing necessary care. One provider, the provider that saw you, is recommending you to go to this higher level, maybe tertiary center like a UCLA, a Cedars, a Keck, or something like that. But the insurance company is saying, well, our rates are better here. Could we just send them here first? Or they'll make you go there first and, get evaluated and spend all that time just going through that rigmarole when you could have just went to the other place that the doctor was recommending to begin with. So patient care based on patient need, avoid those financial incentives the financial incentives to avoid providing necessary care timely, emphasis on the timely. And ladies and gentlemen, that is the 7 basic principles of CalCare. I want to give a shout out to the California Nurses Association who created this lovely thing that I go through every week. So I have to give a shout out to them every week. Thank you guys. All right. So I want to just I know I've kind of got a little backed up with some questions. So I just want to go through and pick up any questions really quick. From Randy, I see women in LGBTQI community will suffer for sure. That is for sure without CalCare. CalCare does include comprehensive reproductive rights and does keep the LGBTQ community in mind. That will be built out. I know that this conversation came up last week about, women's, reproductive health. And in the current language of the bill, it does say comprehensive reproductive, but it doesn't go too deep into it because, like I said, this is an overall bill. But once it starts getting built out, we're going to look at, okay, well, what is already covered in California? We're not going to be looking at nationally. We're looking at here in California. What are we already doing? Which we do have pretty comprehensive women's rights, women's health here in California. Could it get better? Absolutely. Could it be more equitable? Absolutely. And so we need to get better funding into poorer communities and rural communities for women's reproductive health, especially. So if we can build off of what we already have, then I think that we will have a very, very comprehensive women's health and reproductive health program here in the state of California. I'm pretty confident on that. And then I see, another from Randy, a comment, just the same politicians who asked how are we going to pay for it are blocking the passage of legislation that would allow the IRS enough power to force the rich to pay their taxes they owe. Funny how that works, right? Then from Chris Shimizu. Hi, Chris. Once the recall is defeated, do you think Newsom will start taking the lead on bringing California single payer? Personally, no. I don't expect him to take the lead. I do think that he is watching what's going on. I think that the momentum we have built from the bottom is going to be a force to be reckoned with, and he's getting ready to go into an election season. So he's going back-to-back campaigns, but now this is real campaign season coming up. So now, you have to face the same people, the same union, CNA, that you promised single payer in 2018. He's got to face that. So he should be strategizing by now. But I would be impressed if he did jump out. I would love to answer any questions that he would have against it or what his worries would be. I guess right now with Governor Newsom, I understand right now his number one worry is defeating this recall. But I think what I would really like to know, and of course, even people who have been in contact with the staff, I don't think have heard this, is that what would be his opposition? Is it the cost that he's concerned about the most, or is there other factors at play here? But, and I would like to just more so direct, get the answers to what he wants to know versus what to speculate he's holding out on. Like I said, we kind of know some things off of unofficially, but I would just really, want to ask, okay, well, is it that is bothering you, or what is it that would hold you back? And then let me go get you the answers and make you more comfortable with that. I do that with physicians all the time when they don't want to do something or they're hesitant on, discharging a patient or something of that sort. I ask them, well, okay, what is it that is, causing that hesitation? And they give me the explanation and I say, okay, well, let me see if I can do something about that. If it's not medical, if it's not dealing with the direct patient labs or something, but if it's like, oh, well, I'm not sure if they'll have the coverage or if they'll be seen fast enough, I go make that happen. So that's kind of my strategy. But once again, who am I? And I don't have any ear to the governor right now. Dr. Bill, you had your hand raised?
I have the same question. Who am I? Why am I here? No. Yeah, I wanted to take a stab at it, although I always say as an emergency room physician, I didn't do much cutting. I did a lot of sewing and almost never any cutting. But what I would say to Chris's question about what will Gavin do next, and like you said, Gina, he's probably not thinking about what he's going to do next. He's thinking about what he's got to do, to win on Tuesday. But I have heard other kind of politicos say that this is a precursor, a dress rehearsal for the midterms. And he's got to show his worth. He's got to show that he can get out the vote. And Democrats are notoriously bad at voting in special elections and in the midterms. But if he can, rally enough groups behind it, as hopefully he has, the Democratic Party, all the various interest groups, including those working on healthcare justice, across the board, not just single payer, but people who want to advance more access to healthcare in general, even incremental access, then that kind of pushes it into the midterm if we assume that he doesn't get recalled for the moment at least. That does push the issue into the midterm. What happens next is the commission, the Healthy California for All Commission, which has been meeting this year now. They took a year off, which was a huge mistake. I think most of us would agree. But it's run by the California Department of Health, and they felt otherwise preoccupied with COVID that they weren't going to look at revamping the entire healthcare system of California during that time period. Okay, fine. If they had, they could have saved a lot of lives by going to single payer sooner rather than later. But now they're looking at single payer, which they call unified financing, and promised to give a report to the governor's commission by the end of the year. And that will be in time to make a pronouncement, although the commission won't, but it will make a statement related to CalCare AB 1400. So when AB 1400 goes through the committee process at the start of the year, as it's expected to do, then the governor can, use what the commission findings were to advocate for it, and that can help him in his election prospect or re-election prospect for 2022. Will he do that? That's anyone's guess. But there are some signs if you're adept at reading political tea leaves. For example, his biggest adversaries in the legislature, our biggest adversaries, including those two on the commission, Assemblymember Jim Wood, who's head of the Health Committee in the Assembly, and Senator Richard Tan, who's termed out this next term, and hopefully our good friend Dave Jones will succeed in replacing him in the Senate. Dave Jones is a very good friend of the single payer movement, having been the state insurance commissioner in the past. Even those two, but especially Jim Wood, is now starting to talk about how unified financing, meaning a single payer system, will make healthcare better, more accessible, and more equitable for everyone in the state of California. He represents a relatively rural district in Northern California. So it is in his, yeah, it is definitely in his interest and the people he represents to give more resources, as you were just saying in response to the last question. So I think there are political theories that say that the governor will, once he survives this recall, so sorry, it's a very long answer to Chris's question, but if he survives the recall, that he could very well lead the effort to pass CalCare. And so being the eternal optimist that I am, but also for us, you know, as advocates, it means now's the time to push. Now's the time, you know, especially after Tuesday, when we defeat the recall, we need to push the governor, those members on the commission, and every other member of the state legislature to get this done.
Exactly. So, I mean, you know, I always said this is a bottom-up bill. This is your bill. This is the people's bill. And that means the people will be the ones that will push for it. Granted, I know that we can't make the vote. We can't be on the floor doing the I vote, but technically, yes, you are, because the people that are doing those I votes should be the ones representing you. And if they're representing you, then your voice should be coming through their I. Which is AYEI, not like eyeball. So their yes vote should write the eyeball. They're, yeah, like Dr. Bill said, we're watching you. Eyes. So, you know, like Dr. Bill said, like they represent the people. If the people want this, then that our voices should be coming through them. They're just a conduit of sorts. That's the way it should be. I think on paper, that's what it's supposed to look like. Does it look like that? I don't know. So, you know, but when it comes to the governor, like I said, you know, him coming out and starting to support this, I would love that. It would definitely make work a little bit easier. But right now, the governor sits at the top. And like when I say it's a bottom-up bill, we're coming from the bottom up. So I've got the people on board. Now we're getting the assembly on board. And then side note to that, we're also getting city councils, board of supervisors, all local elected officials on board. So here's the governor up here, but you see what we're doing. We're getting everyone on board because the LA County Board of Supervisors voice is pretty loud. They represent over 12 million people. And so their voice is pretty loud. So them coming up, and I'm bringing them up because that's the current hurdle, them coming and saying, you know, sending their, like we supported the resolution for AB 1400 to the governor, then it's like, oh, well, that's a lot louder than Gina's voice, which is coming out like a kitten, like, AB 1400 meow. But when the board of supervisors of LA County send it, it's more like big meow, you know, like, oh, okay. And so now, and then also getting the assembly people on board, not just the committee members, but all the assembly, because we need all their votes. So yes, we are going to focus on those committees, because if it doesn't get through the committees, then of course, well, then it doesn't get to the floor. But we also want to focus on the assembly members. So now we're at the assembly. And so now we're getting closer and closer. So when they're saying yes, then he's got to hear it. Okay, so he's going to hear it. The closer we get, the louder it gets. He's hearing it. It's just going to get louder and louder and louder. So, so right now, yes, it would be great if he would just say, you know what? Yes. Then, you know, then of course we don't have to fight to get so many people on board. But yes, we do, because even if he says yes, if they don't say yes, then there's a problem. If it never gets to his desk to sign, then there's a problem. So right now, like I said, bottom up, but of course we still keep putting the pressure and letting Governor Newsom know that we want this. And so I just want to go to Paul. You said that it seems so complicated to get single payer here in California, yet in other countries appears to not be a big deal. And you said Sweden was able to change the single payer. So what was their strategy? And I appreciate you bringing that up, because we were talking about that before we went live, which is it was a show on PBS that was, you know, talking about the healthcare systems around the world. And I was just mentioning that in this show, which I'll, you know, Paul, if you could drop the link again, it's not letting me copy and paste for some reason. The show, this show was done in about 2008, right? So 2008, we're facing this big, you know, presidential election with McCain and Clinton and Obama and all that. And so, but they were talking about Sweden, because Sweden was like one of the last countries in the 90s that came on board with single payer. And I was saying that one thing we could do, if you really want to look at how, what are we going to be really up against? It's like, okay, well, look at Sweden, look at the fight. They did have a fight. It was not an easy thing. And look at Sweden and see what they had to go through. Now that's going to be your base. Okay. Now we're just going to have to amplify it probably exponentially on how hard we're going to have to fight. But yeah, if you see this link, check it out. It was pretty informative. It was kind of cool seeing a guy go around to different countries around the world and look at their healthcare system and what they did and how they see their patients and everything. I thought that was pretty awesome. Dr. Bill.
Just add to what you're saying. That is a classic film. It's actually called Sick Around the World. It was a PBS Frontline documentary, and thank you, HealthCare for All.
Think of it for save my life.
Thank you, HealthCare for All Los Angeles, for posting the link for it. But a guy named T.R. Reid, who also wrote a book called The Healing of America, which had the same lessons that he learned by going around the world and documenting all these different systems worldwide and how they dealt with healthcare. And it wasn't all single payer systems. Some of them still had multi payers, meaning health in commercial health insurance companies, like, for example, Switzerland. But they also, in those countries, managed to regulate insurance companies down to like 2 or 3 or 4% profit, above operating costs. Now, we know single payer systems operate like Medicare, classic Medicare, operates at about a 2% operating cost, or like overhead in a business, okay? So their administrative cost of running Medicare is only 2%. Well, commercial insurance operates at 20 or 30%, 10 times as much that they take off the top, okay? So that's where your healthcare dollar is going in commercial insurance, as compared to a pure single payer system like traditional Medicare. So if you're in Switzerland and they regulate it down to 2%, in addition, 2% operating cost, 2% profit, that's only 4% compared to our 20 or 30% operating cost, okay? So, there's a brilliant segment in there where he interviews this insurance guy who owns an insurance company in Switzerland. And he says, how can you even survive? How can you make a living on only 2% profit when, American insurance companies are getting 20 or 30% profit? He said, I'm doing fine. My company does fine on the 2% profit that he makes, So that's how, mired down in the politics we are in this country. We are so subservient to big insurance and big pharma that we accept that. We accept that much of a loss. Another brilliant scene I'll just mention from this movie, since you brought it up, Sick Around the World, one I love as a doctor, as a medical provider, is a scene in Japan, where the Japanese system has complete and total open access at the primary care level, to the point where they see their doctors on average 13 times a year, compared to Americans. We see our doctors 4 times a year. So the sickest, most needy of care people, on average, are seen by their doctors in America a third or a quarter as much as they are in these other developed, advanced countries around the world. And so who's going to fare better? Who's going to do better? Who's going to live longer? Say you're an older person. If you see your doctor once a week, it's like every Tuesday is your day as let's say you're an elderly person in your 80s, and you can drop in on your doctor once a week. as part of your weekly routine, you're going to live longer. You're going to have better control of with your medications, your blood pressure, your diabetes is all going to be finely tuned, as we say in the biz. You're going to be fine tuned, and you're going to live longer and better. You're going to have a better quality of life. If you need pain management, if you need, can't sleep well, whatever it is, you're going to be, more likely to get vaccinated. Imagine that. You're going to have trustworthy medical information. You're not going to be so worried or afraid because you had a chance to talk with your doctor just this week. How many of us can say we had a chance to talk with our doctor just this week? Probably none of us, because that's the way it is in America. You're lucky if you get to see your doctor once a year, a couple of times a year. It's crazy. So anyhow, when I first saw that film, it really opened my eyes to both situations. How crazy, we've been subjected to this nonsense of giving our money away to big insurance and big pharma in this country, and how crazy good they have it as a result in other countries, and we could do it too. It's a matter of political will.
Absolutely. And that's the key thing, is political will. I just want to go to Randy's question. What is next after 1400? Will new bill be coming or be forthcoming? After 1400 is passed and it gets signed by the governor, the first step would be to create the board and the committees that go along with that board. There's a 9-person board that is by appointment, and then there is an advisory committee, which is 11 people, which is supposed to be a public citizen kind of committee, broken down by different roles and things within the healthcare system, so that there's good representation within the healthcare system. There's supposed to be, a nurse, a doctor, a pharmacist, mental health provider, basically all elements of the healthcare system should be represented on this committee. And so, so that would be what happens after 1400. Now, would there be more legislation that may need to? Maybe. There are some issues some things have been brought up that may, cause some issues that we might have to address. Like, there was an issue with the GAN limit, and then there was an issue like with federal RISA Act and things like that. So, but the thing is that all right now we can do is speculate that those could be potential problems until we actually start working on it to find out if it's a problem. And then if it's a problem, then maybe we might have to do some legislation, or God awful, we might have to come to the ballot on certain things to maybe lift the GAN limit, which has been in place since the God awful 70s. So, that those would be kind of like ifs, but not, not necessarily could, but I would say it's a good possibility there will be more legislation tied to this. That's why I keep saying AB 1400 is a framework. It's the initial, it is the start. It is not the alpha and the omega, trust me, because it won't even give us enough to build, like to really get it all done. It's the framework is there. It tells you what A through Z will look like, but at the same time, there will be things that will have to be built out on the side to make sure we fill the gaps, especially probably when it comes to the funding. I do know there could be a funding bill coming in maybe next month, a secondary, because to answer that, how are you going to pay for it? Even though there's an entire chapter in AB 1400 called funding, it's chapter 7. For the elected officials who haven't looked at it, who keep asking me how we're going to pay for it. Have you looked at chapter 7 of AB 1400? It's like on, it's in there. It gives you the kind of the house. It doesn't give you a ledger. I'm sorry, I do not have a bank ledger. I cannot tell you how much dollar for dollar things are going to cost right now, but trust me, you don't know how much your current care costs either. How many times do you know when you go to the doctor's office, what everything's going to cost? They don't tell you, because I don't really know. But, but going into chapter 7 of CalCare, hold on, I just want to make sure I don't see any more you know, question. Oh, Paul, yeah, who is going to succeed in lowering the curve in the COVID-19 pandemic? Ooh, not the United States, I can tell you that much. California actually, no, I just saw this, Connecticut, Vermont, and I think Maine have fully vaccinated, 100% vaccinated more than 2/3 of their entire population over the age of 12. So they are actually doing better than us. But I will say California is a lot harder because there's 40 million plus of us, whereas, you know, in Connecticut, Vermont, they're not so much. But I mean, would you really want to piss off Bernie Sanders in Vermont? I wouldn't want to piss off Bernie. I'm going to go get my shot, you know, like I don't want to angry Bernie. He already looks grumpy. Imagine when he's angry. So I want to give a major shout out to those states who are 2/3. We are in California pretty well off compared to like the South for our population, but I do wanted to just give those states. But when it comes to lowering the curve, it would be the states that have the highest vaccination rate, the states, honestly, I think in my opinion, it's going to be the states where people give a damn, honestly. It's going to be the states where actually people care about their neighbors. I'm sorry, Bible Belt, but you are breaking a 10 commandments. You are not honoring thy neighbor by doing the BS you're doing right now. So I think that truthfully, it's going to be the states with the highest vaccination rate, which California is one of them. And it's going to be the states that actually give a damn about each other, about one another, about each Californian, about each Vermont, you know, I don't know what they call themselves, maple syrup. You know, it's going to be those.
What I was going to say was in terms of single payer countries who
single payer countries, not the United States.
Vermonters, yeah.
Vermonters. Go ahead.
I could chime in on that. So it's true, actually, single payer countries, you know, because people have unlimited access to their doctors, clinics, you know, they have trusted medical information sources. So this battle that we're having with misinformation in this country is creating so much vaccine hesitancy, refusal. You know, people are just afraid. And so they don't have somewhere, you know, trustworthy to turn to. So we're now being, you know, we started out because we've had so many pharmaceutical companies doing well in, you know, in the United States. We started out as the supply chain center for the world. So that's why we started out as a global leader in vaccinations. Well, guess what? The rest of the world has caught up with us, at least in the global north, the northern hemisphere. The southern hemisphere is much more challenged. It's both income challenged, has more rural areas. So, so the southern hemisphere, you know, places like most of Africa, for example, are not, you know, they're not yet over the supply chain issues. The northern hemisphere has passed us up. So all of Europe, you know, most of Russia, even a lot of the Asian countries have passed us up as well in terms of percentage of vaccine. Now, I think the global estimate is about 30% of the entire world population is fully vaccinated. I mean, you've got parts of the United States that aren't much better than that, you know, 30%, like, you know, in Alabama and some other of the red states, especially where they're very much being victimized, being played to with medical misinformation, as we know. So, you know, other parts of the world, and especially heavily populated countries, do have single payer systems and universal health care, and especially where at times it can be very dogmatic, like say China, where it's very, you know, restrictive even, but they impose restrictive, very strict public health measures But they can be effective. So they're actually probably better vaccinated. I like to think that the U.S. is going to catch up when we can vaccinate children, age 11 and below. We'll hopefully catch up enough to, as you say, really make a difference on total overall COVID numbers. Hopefully we see the virus, suppressed at that point, whether it's here or elsewhere around the world. But until then, we're very much the outliers still. We're the gold medalists of COVID deaths worldwide.
China, and that's really sad. Like China has how many, like 3 times the population of the United States. And I don't even think they broke 100,000 deaths. And they were ground zero. Wuhan was ground zero. And all people got all racist against Asians and the Chinese people. And I'm like, well, they're over there they handling their shit. So I don't know why y'all hate the Chinese, because I was like, right now I kind of hate you, but so I think that, it's really important that we understand and stop being a pot trying to call the kettle black here. You know what I mean? Like, we're over here thinking that we got it together and we don't. I want to give a shout out to New Zealand. I think New Zealand is kind of like handling this very, Jacinta, girlfriend, I need to come visit. Can we do a political field trip to New Zealand? Can we make this happen? I have to go find some kiwis. I love kiwis, not the fruit, but the actual cute little kiwi. And then,
They have a lot of sheep.
Yeah.
Excuse me.
Some sheep.
Is that sheep taken?
Is that sheep taken? Stock up on some fleece while I'm out there, but I think she shut this country down for one positive case. And that just lets you know when women lead, man. But I really admire that, because you know how much balls I have to take. She got some opposition, everywhere there's opposition. So, I think New Zealand's doing really well. I mean, granted, I can't compare New Zealand to the United States because obviously population is like, I don't know, like a gazillion times more. But when it comes to leadership, when it comes to the leadership of that country saying, you know what, this is a global pandemic, we have to protect our people. You didn't see them fighting like we were fighting. You didn't see Jacinta making this issue to get herself reelected. She was doing this, because she's a mom. Moms, we tend to, go into mama bear, mode real quick to protect. And so, I think that by her making those extreme measures, shutting the country down only for a few positive cases, actually probably saved her country. If we would have done that, I don't think we would see these numbers. If we would have been aggressive in that beginning when it was critical, I went on my rants, and I would say there was a someone needs to mute. So, there was of course the 2 curves, Dr. Bill, you remember those 2 curves that we were trying to prevent? We wanted kind of a slow, kind of low hump curve. And then I called it the scared kitty curve, which was like an arched back cat where it was like, and then comes back down. And I said, come on, guys, we don't want the scared kitty. We need kind of like the relaxed kitty, the cat that's just laying there that we just go whoop and then down. Well, we not only had a scared kitty, we had a scared kitty that's still scared. Because I don't know, it's like we never really came back down. People are like, oh, this is the 3rd or 4th wave. Actually, it's still kind of the first, because we never got to a baseline. So truthfully, we have been kind of in this one humongous long wave. If you really want to go there and say the summer of 2019 or 2020 was maybe we had that lull, at least here in California, we had a lull. Maybe we could be in a 2nd wave, but truthfully, I don't think we're in a 4th or anything like that, because I feel like we've been riding high since the beginning. But anyway, so that just to answer your question, Paul, personally, when it comes to single payer universal healthcare system countries, like I think New Zealand is doing a tremendous job. Granted, I don't know many people from New Zealand to hear, like if they hate it, if they love it, but if they haven't made global news by throwing and protesting in the street about wearing a mask, I'm pretty sure they're okay with it. For the most part, everyone has their idiots. Every country has their idiots. I just think that we just have a mass population of them in ours. Okay, and then Dr. Bill, I'll get to you in just one quick second. And what did you want to add to that really quick before? Because I think this is the next question is kind of a different topic.
Oh, sure. Well, I was just going to share real quick. I like to follow the data, and maybe others in the group are following data too from different counties and things. I live in Orange County, so as Jeanette knows, I've shared with groups in Orange County before too that I follow the Orange County data, but this is what our hospitalization numbers look like for Orange County. And you can see this is what our, I like to follow hospitalizations for COVID because, first of all, everybody in this group has been tested. So it's a group that was universally tested, and it shows the resource need in the community. Okay, so what has the community had to come up with to deal with the crisis? So this is ICU use right here. They talk about ventilators available, in this stat up here. So, but you can see that, in our wave last summer, we got upwards of about 700 admissions across the county. This summer, less than that, but even less in intensive care unit admissions, only about 150 ICU admissions, whereas last year was closer to 230, 250 ICU admissions, and COVID deaths even less than that. And they just recently added, and this, of course, is last winter's peak.
That's the surge.
Before the vaccination, right? And
I'll make that happen again this winter, people.
That's right.
Please.
Well, here's why it's not going to happen, is because this graph here shows these were admissions for vaccinated versus unvaccinated. So you can see, you tell me which color are vaccinated and which ones are unvaccinated. Well, it tells you down here. The unvaccinated are the blue ones, and the vaccinated, you can barely see here, are the orange ones. So there's the power of that, persuading people how important vaccines are. And, and you can do that when you have trusted medical, trusted sources of medical information, like we're talking about when people have unlimited access to their primary care providers.
Exactly. And now more studies are showing that when you have your quality of life is overall better when you have a pretty, kind of steady or provider. And if you look at, when you in the before 4 times before even COVID, but, when people would have a doctor and it'd be that doctor, you might have a doctor that's new, that when you start seeing him, and you may see him till he retires. You may see this one doctor for 20 years. Now tell me that doesn't create a trust. I see primary doctors, very rarely, but I know, and then Dr. Bill, I know your history, you probably chased your dad around, he saw patients in the hospital too. But a primary doctor will come and when he's connected with you, he cares about you. And if you're in the hospital, I've seen primary care doctors come visit, because they want to be nosy in your chart too, but they're coming to visit you. Even if the second motive is to go be nosy in your chart. And so, but it just warmed my heart, like I had a patient last week tell me that she told me, oh, my primary doctor just left. You just missed him. He came to visit me. And it warms my heart. It really does give me that cute little fuzzy feeling, because I'm like, oh, your primary doctor came to see you. And that's what happens when you build that level of trust with your primary. And it's so important, because it overall really does give you a better quality of life, because that doctor knows you, he trusts you, and you trust him. So when you come to him saying, I'm having this pain, it's not going away, I don't think it's this, I think it's something else, he's going to trust you, and he's going to do a little bit more workup. That's the relationship I have with my own primary. I've had the same primary doctor since I moved here 8 years ago. And
single payer countries have half the malpractice that we do, for exactly that reason. You're not likely to sue someone that you think cares about you.
Exactly. And so that's the thing. And that, but they listen to you. And when, because a lot of times I also hear in my work, and I'm sure Dr. Bill, you've heard it too. I told my doctor this wasn't it. I told him I still felt bad. And well, when you don't have a good relationship with your doctor, you know, they're going to go through what they're taught. They're not going to immediately jump a few steps. They're going to go through kind of like their kind of like pathways. Okay, well, we're going to rule out this, rule out that. They're going to, if it looks like a duck and sounds like a duck, they're not immediately going to go think it's a horse. They're going to try to treat it like it's a duck. Okay, so, but sometimes there are patients that, yes, it actually was a horse. And if you would have had that relationship with your primary, not all the time, I'm not saying it's 100% perfect, but if you would have had a very good relationship and you would have said, you know what, I don't think it's that. I think it's something worse. I feel like it, I really do feel bad. Your primary doctor will know you. He will know your nuances. He will know what's normal when you come in versus when you're not looking so good. You know, my doctor knew when I was anemic, you know, and I had never been anemic a day in my life. So, you know, I think that that is the key, one of the biggest important things about CalCare. Now, I'm a equal opportunity accountability person. The accountability is still on you to go, hey, you can have CalCare, but a lot of people have insurance. And trust me, these insurance companies love this. This is free money for them. You have insurance, you just don't use it. You don't see your doctor, not even annually. You just are paying because it's through your job or whatever, and you're not even utilizing your benefits. And so that you're our bread and butter for the insurance company, because that's just free money for them. They don't have to pay a dime for you. So even with CalCare, we'll cover you, but you still got to go use it. You still got to go to the doctor. You know, CalCare isn't going to actually make you go to the doctor. We're just going to say, well, you can go, and you're not going to go bankrupt for it. So, you know, that's the cool thing about CalCare and the importance of establishing that with the primary care doctor, because it is, primary care should be your medical home, which is a terminology we like to use, saying your primary care doctor should basically be coordinating your care. You shouldn't wait to the hospital to coordinate your care. It actually should be your primary doctor coordinating all of your care. He is your medical home. So, you know, the ER is not your medical home.
He or she.
He or she, sorry.
Mine's a she.
They are your medical home. And so, you know, your ER, the ER is not your medical home. Dr. Bill was not your medical home, even though I'm pretty sure he saw patients that pretty much that was at their home. You know, so, but your primary doctor should be your medical home. And so I just want to go to Danette. I saw your question about, this was a good one. Healthcare and climate. Yes, they are married. They are intersectional. We know environmental justice and healthcare justice go hand in hand. They're skipping down the road together. But, you know, what are we doing to individually to pressure Congress, Manchin, and Sinema? I actually, you know who brought this up to me? My mom. Hi, mommy. My mom, who is a Democrat in Indiana, so pray for her. She was bringing this up about, you know, how the Democrats are not, you know, going as hard as they want to. And my mom's a boomer. So, hey, Democrats, if the boomers are starting to rebel against you again, like they were in the 60s, you got a problem. So with Manchin and Sinema, I know that people are pressuring, and of course they're trying to primary. I think for sure Manchin has a primary, you know, somewhat candidate. And I think that, you know, honestly, we should try to see what that candidate's about. He's going to need that nationwide support. Whoever, or
Sinema household too, sorry. I think
I'm sorry, what?
I think Sinema's being primary too.
Yeah, Sinema's being primary too. I haven't heard who is stepping up yet, but they are being primaried, but we know how this works. I think if you're tuning into this, you're a little bit in tune. You know how this works when you have big names like Joe Manchin. You know that anybody primarying him is going to need every ounce of support. My hope is that the party now will not stand behind him. In my opinion, if I were in high-level DNC leadership at this point, and I'm speaking to them through this, I would be ready to pull them and kind of really get rid of, they're actually, because they're not even following the DNC platform that, you know, I will not say if I voted on it or not, but anyway, they're not following it. They are not helping the Democratic Party by any instance. And I think that it is time for them and the party to part ways. And I think that that is something that our party leadership needs to consider. And I know it's in there. I just can't quote it right now. Just like, you know, with the LACDP, which I'm a member of. If I were to do some crazy shit like Manchin and Cinema have been doing, they would have pulled me easy. And you know, so I don't know why they're holding on. Yes, it does make us, it will kind of, you know, it would suck if they were to jump and turn Republican in that seat, because then of course we lost majority. And that could be a reason why they're not pushing so hard. But at the same time, it's like we've lost either way. So might as well just get rid of the bad blood. And then support a strong primary candidate, because we can win. Manchin is definitely got flaws, and so does Cinema. And so there, to me, could be low-hanging fruit elections if we get the Democratic Party to support whoever's going to run against them. And that is how we get them to pressure. The party has to do it. I don't think that the public, I mean, the public pressure, but I think that it's really if the Democratic Party itself, you know, in those states or at the DNC level, actually pressured them and told them like, hey, if you don't do this, we're going to do that because you are opposing our commander in chief. And in my eyes, that's flipping treason. But I'm not going to, I don't want to say those words because now QAnon has hijacked everything that anyway. So I just think that it really, the high level leadership should definitely be, but of course we can do what our grassroots do. Go ahead, Dr. Bill.
So I'm just going to add to that, that a lot of us are involved in you know, political, you know, kind of advocacy, volunteering, like you are, Gina, with the Los Angeles County Democratic Party, California Democratic Party. But equally important is outside of the established political, you know, outside of the political establishment. So there's the inside track, like you're talking about, and also the outside track. So, so I think politicians are responsive. They always have their finger in the wind, and so, you know, and what moves politicians, you know, right now in this era of politics is too often money, right? It's too often the influence of big corporate dollars and an influx of cash into campaigns. But the other thing that can influence politicians is the people. And if we get enough people on the side of, you know, what's right, we can actually influence a lot of people. I know there's some Bernie folks in this group, you know, that we influenced a lot of the discussion with, you know, small dollar donations, but just from a lot of people. I mean, Bernie Sanders had more volunteers than anyone's ever seen in a presidential candidate before. But we can also run campaigns like this one, where you're raising awareness through the internet and or locally in physical town halls or meetings, you know, just in living rooms and discussion groups. So I don't think any of that plays a backseat. I think it's equally important to the political campaigns, whether they're, you know, through established political parties or otherwise. So kind of inside and outside the Democratic Party, or inside and outside established politics. It's all important.
All of it. I don't down anybody. I don't like it when others down people for their strategy. You know, I stay inside the party because somebody's gotta. Imagine what happens if all of us just left. Good luck. But, you know, people building and doing things outside, focusing on issues, for example, that is perfectly fine. Like, you know, this is definitely a fight. So the more people we have in different places on the board fighting for the same things, the better off we are. But yes, Manchin and Cinema pissed me off. And I'm just like, oh, you guys are so lucky I don't run shit around here, because you guys would have been done.
Well, we know a lot of people have been arrested recently protesting Cinema. Kristen Cinema's positions and caving in on, you know, on what are very well-established, very clear-cut policy platforms of the Arizona Democratic Party. and she's caved on those platforms. And people went to her office, and and were arrested for civil disobedience there. So I mean, that's going to happen more and more the more they do this, and the less that they comply with the rest of their delegations in Congress. It's going to happen more and more, in their home states. And how much of that will they put up with? Remains to be seen.
Well, but we can avoid all this if the party would just act and act a little bit more aggressive. But I just want to go to Randy's question. Randy asks, what happens in if AB 1400 should not pass? Well, you're going to piss off a lot of people because now we've made this AB 1400 has been real public. Now the people are becoming more familiar that this exists. And getting it through, for example, LA City Council signing on to a resolution unanimously, says a lot about this. And so I think if AB 1400 should not pass, we don't stop. SB 562 didn't pass, and a few years later, here's AB 1400. So, it will be back to the drawing board, but I think now it will be kind of more aggressively looking at who's in office, because we know it's not the bill. The bill is one of the most comprehensive, best single payer bills that have been written in this United States. And so I think that now we're going to be aggressively going after these seats and trying to get more people in that will be voices of the people. Like I said in the beginning, your elected officials are not there to implement their will. They're actually there to implement your will, the will of the people, the will of the voters. But I think what happens is that they get there and they start thinking with their mind, and they're very single-minded, but not for single payer. They're single-minded for themselves, and they're thinking, well, I think that this, and I think that, and I think, and I'm like, no, it's not me, it's us, so shout out Bernie. But it's not it's we. And I think that right now there's a lot of I think, and I'm like, it is not about you. You just have to be a singular person that says things in that place. But it is about the people. And I think I just don't want to. I definitely am very conscious about what happens next after this. Gina's is going to take a big vacation and probably have some therapy before I go a little bit too negative. But I do think that I'm not going to implicate myself with my thoughts. Paul, you had your hand up.
Yes, I just want to include that in the comments section, I happen to put our CalCare toolbox in, which shows the actions you can do to prevent that from happening. It's in the comments, and anybody is welcome to look at the toolkit. It pretty much gives you all kinds of little tools such as text banking. The latest text banking technology is wonderful, by the way. We have a text bank going on every Friday at our happy hour, and it is just amazing. You can, within 5 minutes or 6 minutes, text like 300 people, and then you just wait for them to reply, either to opt out or to be part of it. And it's just absolutely amazing. And you get some real, cranky people too. But other than that, it's just so much better than phone banking to me. So in the toolkit there, we have all the options you can do to help us fight in the comments in Facebook. So thanks for letting me share.
Thank you, Paul. Yes, absolutely. So yes, we will be hosting phone banks on Fridays for the rest of the month, reaching out to key districts. We're working with CNA on this. So this is CNA. I wish Healthcare for All and PNHP. We're using CNA's resources because they have the money. They have more money than us, but their system through text is very efficient and easy, and it's actually more online. And so please join us for a virtual text bank from 6 to 8 on Fridays. And Paul just posted the links. Also, you can find out on by following our page, Healthcare for All Los Angeles. Dr. Bill.
Well, I just saw Dennis's question in the chat about his assembly member more or less dodging a question, or at least a staff person for his assembly member is dodging the question about the status of AB 1400 in the legislature. So, Dennis, I would just say that that they're kind of right, but not really right. They're using a very negative slant on the status of the bill. It's not stalled in assembly rules. The author, Ashkaura, has held it back from being considered in any committee of jurisdiction. And the first committee to decide on the bill would be Rules Committee. So my understanding is Ashkaura has held it back from any decision to be made on the bill until the legislature starts up with bills, the 2-year bills, because he turned it into a 2-year bill. So that happens at the first of the year. So that's when the author can elect to release the bill to go through the committee process. It's the author who did it, not the Rules Committee. So they're making the slant look like the committee is not taking it up. That's not the case. It's the author who's saying, wait, I'm waiting to get more support for it. I don't think they expect a holdup in the Rules Committee. I think the holdup right now is in the Health Committee. And like I said earlier, the chair of the Health Committee is Jim Wood, who's on the commission. And I think when the commission comes out with its report, hopefully, I'm the eternal optimist here, but I don't just sit around waiting for it to happen. We're going to push. But hopefully the commission will say, Governor Newsom, it is time to move forward with a single payer system, or what they call unified financing. At that point, even Jim Wood can be hard pressed to not let it, move through and pass his committee to go on to appropriations or whatever other committees it has to get to the assembly floor. If they don't allow it to get to the assembly floor at this point, that will be huge upset, for our democratically controlled state. And frankly, I think a huge negative statement on the way things are going for the midterms. So personally, I see it going through the committee process, but it's not the committee holding it up now. It's Ashkaura himself.
Exactly. So yes, he is, Ash is, held it back on his own, with the consultation, of course, of, other supporters and co-authors, but he held it back, not the Rules Committee. And it's because this bill is monumental. It's heavy. Like, to think that this would have been a 1-year bill, that's if we would have had a progressively Democratic supermajority, and we know we don't. So it was smart, because we could have seen this bill go down in a blaze of glory, like papers on fire, just falling all over the place. That would have been AB 1400 had he not made that critical decision, which we, at first we're like, what? I remember when I found out, and I got on the phone, I was working, I got on the phone, I was calling everybody, what the hell is going on? And blah, 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 blah. I'm on the phone trying to get CNA. I've got 2 phones up to my ear trying to figure out what's going on. But then, when you stop and think about it, you think about strategy, it was the best thing that could have happened. And he made a very good call on that. And I think that now it gave us more time to build momentum. It gives us time to go talk to all these people on the Health Committee. Hello, Autumn Burke. Hello, Freddie Rodriguez. So, people who were not certain about, where they stand on it. Hello, Jim Wood and Chad Mays. We have time as the people, we're not going to be on the floor of the assembly, unfortunately. But we as the people have time to go talk to them. And now they just came out of legislative session, so they should be at home. So they should be in their home districts now. So feel free, you know, CNA will be definitely pushing this in a little bit. In the next couple of months, you're going to see a huge push for these ledge visits. But, you know, if you're politically savvy or if you already have a relationship with your assembly member, I know some of us do, some of us are delegates to the California Democratic Party already. And you already know your assembly member, you already talked to them, you have talked to them. Feel free just to nudge them, you know, just say, hey, you know, I haven't heard, where do you stand on this? It wouldn't hurt. And then, yes, they're going to get more. I would love to see more people from the public who aren't involved get involved and start talking to their assembly people too. And that is how we're going to get this. We're kind of just greasing it up for it to slide through, right? The more people on these committees we have already either okay with it. I'm not asking everybody to be a co-author. I would love it, but I'm not asking that. I'm asking you to give it a chance. You know, if you don't have to love this, okay, I get it. You may feel that you're comfortable. You may feel that the system works because it worked for your grandpappy. I don't know. But at the same time, I'm just asking all of the elected officials, all the assembly people to at least give this a chance. Or let me say a majority. I can't get all of you on board, I know that, but a majority, I would just ask, give it a chance, you know, because imagine how much you can wag your finger in my face if I'm wrong. I know I'm not wrong, but if, you know, I'm just asking. Dr. Bell, what's up?
Hey, papers on fire? What? Papers on fire?
Papers
on. No, I was just going to add, and it doesn't have to be just your own assembly member. If you're, you know, especially if you're active in the Democratic Party, you know, I've got a Republican assembly member. You know, I've been to him. You start talking single payer to him, it's like talking Greek or Martian to the guy. I mean, he really, you know, he doesn't understand it at all. It doesn't really.
But will he talk if you talk investment? Because I'm I'm coming for the conservatives. I got
of course.
Let's talk investment. Let's take single payer. Let's take the word single payer out. Let's
try
talk
that.
about investment. I have an investment for you that's going to yield you a XYZ on the return. I guarantee you, you don't even have to say single payer. As soon as you say investment and yield on return, you're perk. I'm like, hey, let's talk dollars and cents. And then it'll be like, well, it's this thing called CalCare.
Now, if any of these members of the legislature happen to be on a committee, they no longer represent just the people in their district. They're representing the whole state by serving on that committee. Okay, or if they're in a position of leadership in that body in the assembly. Okay, so they represent the whole state. In fact, every member of the legislature is voting for every person in the whole state, not just the people in their district. So, you know, so never buy into this. They're only going to listen to you if you're from the district. You know, you just tell them anyhow. And if a lot of us are involved in politics, you know, for that reason, that you can get the ear of one of these elected officials. Again, they're more often going to listen to money, but if enough of us tell them these things, then they're going to listen to us too. You know, it's the people versus the money versus the people. So people have to speak up, or they're just going to follow the money.
Yes. Absolutely. So really quick, I just want to get to this question from Randy, and then I want to go into a little bit about what the bill says about financing, because I realized this has been a really good conversation. We're already close to 6:30. And so I wanted to, Randy had asked, being a 2-year bill, how are we going to get how are we going to get the speaker to get a hearing? Well, the good thing is that our lovely author, Assemblymember Colriff, is actually already talking to the speaker. You know, he's like, Asha's pretty savvy, you know, and so he's already talking to the speaker. I'm not sure, you know, I would take lead from him. I'll be honest, I'm not 100% sure, like a direct answer to your question, Randy, but I know that, you know, with me working on this bill, I am, you know, have been also kind of, you know, poking elected officials. He's one of them, because I just want more info. I want to know what he knows all the time. And so I think that if he tells me that something's a problem, I look at it as a problem. And right now he has not indicated to me that the speaker is an issue. I know historically, because of SB 562, we all kind of are looking at Rendon like with some side eyes, but I'm taking lead from the author. And if, he's telling me to focus on building momentum and getting everything, I'm going to trust him. I mean, he's one of the realest people in the assembly I can think of. And so, I think that if he's saying, Rendon is open and, then I'm going to go with that. But if he says that we need to focus on it, I will let you guys know. So I just really quick, I wanted to talk about, in the beginning, the thing was, how are we going to pay for it? And people keep saying, like, they get stumped on that question, and you're getting stumped on that question because there's no direct answer. People want to know how we're going to pay for it, and they want a direct answer. And the same way we pay for Medicare, Social Security, and a bunch of other things, it's really complicated, right? Yes, you have Social Security tax, Medicare tax, all the federal taxes and stuff like that, but there's other factors going into that too. Of course, it's been nitpicked, and now we're running at, of course, a issue where the money is running out in those pots. If our elected officials that come in office soon with the midterms and beyond aren't pro Social Security and Medicare, we might be a little screwed when the money starts to run out, because we need more funding into these programs right now. And the reason why I'm saying that is because part of the funding mechanism in CalCare is the federal waivers, the innovation waivers, basically asking for us, the state, to be allowed to get those federal monies for these programs, the Medicare chip, the remaining monies from Medi-Cal, because Medi-Cal or Medicaid is a split, like it's mostly state funded, but there is a little bit of federal in there too. And it's asking the federal, for us to be able to, because we have this comprehensive program that covers everything that these federal programs cover. So that's one thing about CalCare, is that it cannot not cover something that Medicare covers if we're going to ask for those funds. So if we're asking for those funds, we are saying we're going to cover everything Medicare covers. We're covering everything Medi-Cal covers. We're covering everything CHIP covers, which is the children's health insurance plan. We're covering everything the ACA covers and more. So we're not going less, we're going and more. And so that's one of the, funding mechanisms, but we do have to get those. And there's been some talk about, the strategy about the waivers and stuff. I'm not going to go into that, but if we had this comprehensive bill that is AB 1400, when we applied for these waivers, I think we would be better off. And so Chapter 7 of CalCare of AB 1400, it's like one of the last chapters. It's in the back because, they got you excited by letting you know how much it's going to cover. But, it talks about, of course, applying for the waivers. And then also it talks about establishing the CalCare Trust Fund. So I'm reading from this, the CalCare Trust Fund, and it will be created by the state treasury for the purpose of the title, and be administered by the CalCare board. So a lot of this is the reason why it's also important that we have a good board appointed. Unfortunately, the board will not be elected positions, which maybe that could be an amendment, but no, you know what, maybe I don't want those positions elected, because then we're going to fight the insurance industry at the ballot. Maybe they should be appointed, and we should just pressure those who appoint, which will be the governor and Speaker Rendon and Tony Atkins. So, the thing is that, all monies in the fund, or any monies in the fund that are unexpended or unencumbered at the end of the fiscal year will be carried over. So if we have a positive balance, in 2022, then that positive balance, it'll just keep building, right? We'll just keep having money. It's not going to be, that's where some people, I think it's that portion where the whole conversation about the GAN limit could be an issue too. And then the issue of having, we have to keep a certain balance in the state budget, of course, to be able to fund this. And so there's some issues with these old archaic Republican measures that were put in place long before I were born. And then the board shall establish, I'm just going over some points I highlighted, I'm sorry, but the board shall establish and maintain a prudent reserve in the funds to enable it to respond to costs, including those of an epidemic, pandemic, natural disaster, or health emergency, or market shift adjustments related to patient volume. That's key. That is very important because people have already asked, well, what happens with the next pandemic? You know, like if you're, you know, if it's a state funded thing, how are the hospitals going to be able to, you know, bring more staff in or pay staff more if they need, you know, to have, if we have another COVID event and, you know, but the hospitals will be operating under a global budget. And trust me, that global budget is not going to be so lean that it's going to not give them any wiggle room to pay staff overtime. But the fact that in the bill, the board has to have a reserve. So not only do we have to fund it, we also have to keep enough in there for unexpected things to happen, like a pandemic. And that's very smart. You know, you should not operate that leanly. And that, unfortunately, is what a lot of insurance companies do. Insurance companies operate very, very lean. Their profit is not like, they're not necessarily looking at, well, we need to keep this much reserve to hire more staff if things get crazy. That's not what they're looking at. They're looking at, okay, member growth to revenue growth and revenue, and they're just looking at growth. They're like a hungry caterpillar. And so, you know, they're not looking at it like, oh, well, we, you know, maybe should keep this for employee retention, or maybe we should pay out, you know, this or that, something that a need, you know, or maybe we should look at improving our systems. It's more so about, okay, well, oh, look, we hit this profit margin on 2021. Can we hit, now let's do some numbers, and can we get a 3% increase above that? So you see what I'm saying? That's kind of the thought process going on the other side. So in this bill, the reserve is not necessarily to pad the board's incomes or to give out big bonuses or to lobby. This is literally a reserve for unexpected expenses like a pandemic, a natural disaster. We live in earthquake country. Who knows when that thing, where we're just going to rock and roll. But, you know, that is where this reserve fund is for. And I just want to emphasize why that's a difference, because like I said, on the insurance industry, the reserve now becomes, well, it's not a reserve, you know, and it's just like, okay, that's a new goal. Now we've got to get this much profit because we got it in the previous year. Dr. Bill, you want to add?
I do. And thanks, Gina. That was very detailed and didactic. I want to just point out that in terms of the funding discussions of mechanisms, et cetera, I think, like you said, AB 1400 in that chapter 7, it sets up the kind of guidelines or outline for it. The details in those guidelines, you know, it says it's the intent of the legislature to pass more legislation. And that means that this bill, when it's passed, it, you know, passes the gauntlet on to the legislature to then set up the exact financing mechanism. Now, that's not all that difficult to do, because every time that a single payer system has been proposed for California, which actually dates way back, as I've said in these forums before, goes all the way back to the year I graduated high school, before, you know, a lot of you were even born. You were just fetal Americans, gametal Americans at that point. But it was when I graduated high school, it was 1971. Speaker of the Assembly, Willie Brown, and the President Pro Tem of the Senate, John Burton, attempted to pass a single payer system back then, 1971. But you don't have to go back that far. You can just go back to 2004, when Arnold Schwarzenegger vetoed SB 921. A proposed mechanism, you know, was submitted. They always have a proposed mechanism submitted with every piece of legislation, and there will be one for AB 1400. Okay. During the committee process, committee hearing process. But this one back in 2004 was submitted on behalf of the author, who I think was Sheila Kuehl in the Senate back then. From this group, the Lewin Group, a very respected independent financial analyst group, proposed a financing mechanism. And this one had benefits to individuals and businesses, savings, pocket, in your pocket kind of thing. Savings to businesses, as you can see here, per employee in large business, small, medium, and large size employer groups, up to 500 or more employees, they would save upwards of $2,500 per employee per year. Those were the savings if the legislature followed the proposed mechanism of this group that was submitted to them, the Lewin Group. Okay, so this is not voodoo, it's not magic, it's done, it's analyzed by respected economic analysts, and you come up with these proposals. And the legislature just has to go ahead and say yes to one of them. It was done with SB 562 by a group called the Perry Group, based at University of Massachusetts Amherst. Again, similar findings: saves money, saves lives. So that it's not some magical thing. We know how these things can be paid for. We just need the politicians in Sacramento to go ahead and agree.
Yep, and that's where we come in. And right now, like I said, the thing about it is just having a conversation. What is it that you're against? And that's my strategy. You don't have to go and ask them that if you're not comfortable. Because I need to know, I just want to know, like, I feel like I'm beyond now the political jargon and BS, what you tell your normal constituents. I'm like, look, talk to me like a coworker, because I pretty much have been around as long as some of these people do. And so, that's the thing, is what is it that you're against? If it's just the financial cop out, how are we going to pay for it? Okay, well, let me go through this and let me pull all these studies and all that stuff. So what are you against? I basically want, I grew up under the saying, tell the truth, you'll shame the devil. And that's where I'm coming, because I know that there is a truth that is not being told on why they're against it.
You have to ask them, do you oppose the saving money part or the saving lives part?
Yeah. So, I mean, there's that, but it's kind of like, tell the truth, you'll shame the devil. Why are you against it? Tell the truth. If it's because of that, that Blue Shield money, tell the truth. I mean, I'd rather you tell the truth, because I already know the answer. I just want you to tell me. Anyway, I want to go to, we'll get back to finance. I just want to go to Chris's question. Once AB 1400 is passed and we actually get a single payer, how difficult will it be to get it overturned or taken away by the opponents? Would the Supreme Court be able to find it unconstitutional? In a Republican Supreme Court, they're going to find something. But the thing is, this is the almighty California, and we have some of the most brilliant minds in the world. We've got UC Berkeley here. We've got all these, we have Stanford, we have all these universities here that, we can find protection. I would be extremely worried, yes, that this is going to go to Supreme Court. This will, the right wing will have a hissy fit, and maybe some of the moderate Democrats. And yes, I can see this definitely going to Supreme Court, but you will find me in Washington, D.C., because I know personally, I'm not going to allow that to be overturned just because, people fell asleep at the wheel and let the Supreme Court go a little bit too right wing. And so, I think that it will be there, but I don't think that it's not going to be easy to overturn. But it will be until, I would say, 5-10 years out. And people finally just get used to it. It'll be, to me, a constant attack. Go ahead, Dr. Bill.
Well, I'll just chime in on that too. The U.S. Supreme Court has actually been favorable to the states to decide on these things, and that's where this whole thing about the states being able to refuse Medicaid expansion came in. So California chose to expand Medicaid, which is Medi-Cal, of course. But states, especially the red states, have chosen not to expand Medicaid. And even though the federal government was paying like 90% of it and that kind of thing, just insane, their refusal to do that. But I mean, as far as we can tell, it seems insane. So the U.S. Supreme Court, and if the California Supreme Court, somehow for some reason which nobody expects, were to somehow decide it unconstitutional in this state, it could then be taken to the U.S. Supreme Court, which would likely decide in favor, actually, of the legislature in California passing that bill. Some people think that a law, AB 1400, would have to be backed up by a statewide referendum, in support, in order to be convincing to the state Supreme Court, in particular. But it also brings up the Prop 98 GAN limits, which have been more or less kind of enshrined, in my understanding, in the state constitution. And that is, whenever any tax dollars are collected in California, a certain percentage of that has to go to education and that kind of thing. I think that what I understand about that is that those are monies that are directed toward the general fund and not towards this fund. This is a specific fund. So tax dollars collected to go to this specific fund, I think, are actually exempt from Prop 98 and the GAN limit. So
that is exactly the question that has not been officially answered.
Right.
I asked directly that question about, since in this bill in AB 1400, it states it is establishing the CalCare Trust Fund with the state treasury.
Mhm.
So we're separating ourselves from the general fund, which is
That's
affected
right.
by the GAN limit in Prop 98.
Yeah, it's a way to get around those legalistically.
See, people who wrote this were smart. They knew California. They were smarter than I. I would not have thought about that.
But the way we really have to be vigilant about it once this is passed is undermining it piecemeal, bit by bit.
Just like Medicare.
By,
being
death
undermined bit by bit.
by stabs by 1,000 knives, kind of thing. And just like you're saying, Medicare, Medicaid, they will attempt to profitize, introduce things into it that corrupt its being a pure single payer type system, and introducing a so-called private public partnerships, that kind of thing, which will definitely siphon off resources. It's like the voucher system for public schools. It will take away resources from the public need and put them into private hands. I actually don't like that word private, because there's nothing private about it, except that it's done behind closed doors where we can't see what they're actually doing, like sleight of hand. It's commercial interest, taking away from the public and giving it commercial interest. So that's where I think you run into the big trouble, Chris, in terms of trying to undermine our effort.
Exactly. So that's why I say it's a fight. It's going to always be a fight. It will always be under attack because people will always be trying to do that, just like with Medicare. They created Part C, and that let the private insurance companies get their grubby hands on federal funds. And while Part C does offer, it may offer more services. Some Part C plans will offer vision. Some Part C has hearing, which Medicare A and B doesn't cover. Some Part C will even cover some dental benefits. And that's like, well, what's wrong with that? That sounds good. I'm like, well, why do you have to go to a private insurer health plan with a very restricted network when all that money just could have been, yes, Part C is Medicare Advantage. Thanks, Paul. That could have been just put into the original Medicare, the Medicare that Lyndon B. Johnson passed, the Medicare that the Civil Rights Movement fought for. Why does it have to go to a health plan? Why can't that money just go back into the original Medicare? I mean, it's like, why are you creating an additional middleman? I don't understand it, just, and then like to have them, I mean, if you think about it, how much they just spend out in advertising and printing fees. Medicare open enrollment's getting ready to start up in October. And God, I mean, if you're 65, good luck. You're about to get inundated with flyers, just like campaign season. And yes, it goes back to the spaghetti bowl. So that's the spaghetti bowl. That Medicare Advantage just added another big clump of spaghetti into this already confusing bowl. We're trying to not have a confusing bowl. We're actually, trying to kind of straighten the spaghetti a little bit so you can see through it, make it nice and clean. There we go. Just like Dr. Bill said, or showing nice and clean lines. We want clean lines so that we know where our money is going and how it's being spent out. But when you have a spaghetti bowl, you don't know what's going on. You don't know what noodle ends where. It's like a big, gigantic maze. And so just to go into the CalCare Trust Fund, as we get into the last 15 minutes here, the CalCare, sorry, itchy nose. The CalCare Trust Fund is supposed to consist of the monies, enacted under the legislation, and that's the federal money from the waiver, requirements for the, like we've been saying, the Medicare, Medicaid, CHIP. And then, you have the monies from the state Department of Health. And then you have the like federal and state monies that are authorized under Title 20 and the Federal Social Security Act. And then you have state monies that would otherwise be appropriated to any government agency, office, or program or institution that provides healthcare items or services or benefits covered under CalCare. So you cannot, if you're going to opt out of CalCare, okay, fine. But you can't provide the benefits that CalCare provides and charge people for it. That's basically what this is saying. You are not allowed to charge people for what they would get for free if they were under CalCare. And that's why we make the joke about having your cosmetic buy-up plan for your Brazilian butt lift, because that is not covered under CalCare. But, nonetheless, but it can be if it were medically necessary. So if a provider, like I said, opts out, which honestly, if this passes, and I'm expecting some people to buck against this for the first 2 years, I am, and I guarantee you on year 2, they will be the first ones putting their application in to get under CalCare, because they will see that hit in income. You will not find one damn doctor out here that says, I don't take Medicare. Now, keep in mind, I didn't say Medi-Cal because there are plenty of providers that don't take Medi-Cal, but I have not heard of one provider, one hospital, one nursing home, one anything saying, oh, I don't take Medicare. I have not heard of that. And that is because Medicare is bread and butter. It is guaranteed payment. Medicare dollars are actually, to them, more guaranteed than plan dollars. They don't have to fight for the Medicare dollars like you have to fight for the health plan dollars, believe it or not. And I know how people feel about the federal government running shit. I know, don't get me started. We have our issues. But when it comes to getting paid from the provider standpoint, you do not have to chase down those Medicare dollars and fight for them like you have to fight health plans. I'm just putting that out there. Sure, Medicare, it may come a couple of days late. That payment from Medicare may come a little late, but you won't have to fight the way that people fight. You won't have to be calling health plan medical directors to do peer-to-peers because they denied your claim for something stupid. You won't have to be doing that. And you won't have to do that under CalCare either. So I think when providers see that and understand that initially, because we got some conservative doctors out here too. And so once they get over that initial, I think that, like I said, after the first 2 years, they'll be clawing to get back under CalCare. Go ahead, Dr. Bill.
Well, I was just going to say, because people, I'm sure you get asked to, all the time, although you're used to dealing in with the system, that spaghetti bowl, commercial insurance system and how it interfaces with public insurance. But people ask us all the time about concierge medicine, and it is true that there are doctors out there who only take cash patients, and because they're kind of fed up with insurance of any kind. And usually you see them in hospitals that can accommodate those kind of patients, and oftentimes they're in the super wealthy class, not just wealthy people, but super wealthy. I mean, we're talking about not, their corporation, or maybe they have a foundation that pays their, cash for their medical expenses. So those folks don't have it. They're too wealthy to have insurance even of any kind. I mean, an insurance CEO, an insurance company CEO doesn't own the product that they sell. They don't have medical insurance themselves, right? I mean, you don't consider that, but it's true. They can't relate to the rest of us who have medical insurance. So it's kind of curious the way it's set up. I once debated one of them on healthcare reform, and one of those doctors who doesn't take insurance of any kind. All they take is Visa or American Express, and it was kind of shocking to me in their ability to tune out the rest of the mass and just service that one clientele. And it was at a hospital. This one physician worked out of a hospital here in Orange County, which I won't mention the name right now, but everybody here knows which hospital that is, because it's like right, on the beach with ocean views kind of thing. So that's what we're talking about. There'll still be that kind of concierge service. They're not going to outlaw, those kind of the super wealthy class from paying cash, but it will be illegal to offer an insurance plan that covers the same thing, which is all essential medical services covered by CalCare.
Exactly. So, that is the key thing. And like I said, those providers are a drop in the bucket overall. There are not that many concierge medicine providers. There are physicians that moonlight on the concierge side. I know several who, go and do Botox or whatever, just a moonlighting because student loans are real. That's a whole nother problem. But that's not their primary income. That is their secondary kind of like, gig, side hustle. And so they do that as a side hustle. So concierge, a lot of concierge doctors are side hustling it. They're actually primary, they're internal meds who are practicing, they see patients, because it's not uncommon, like doctors hustle their asses off. And you'll see a doctor who sees patients in the hospital in the morning, he's in clinic in the afternoon, and he might be doing consultations or doing some research or whatever in the evening. Three income streams happening right now. And, I question how are you effective when you have to split yourself that way? But I'm not knocking your hustle, but nonetheless, when it comes to concierge medicine, just know a lot of those concierges are still seeing patients at a regular level. It's just that they're kind of doing some side hustle too. If not, then like Dr. Bill said, they are taking care of the ultra wealthy and have built a clientele, but that is hella territorial. If you have built your ultra wealthy clientele, you are not going to let them go. So, no people just thinking that, doctors can just jump into that. No, you got to build clientele to pay, your bills. And that is where territory comes in. And there ain't that many billionaires out there. It's only 150 something in California. So you got to put two and two together. But anyway, so I just wanted to say, before we wrap up, the CalCare Trust Fund. So now we've got this fund, hoping this fund does kind of skirt around some of these implications like the GAN limit, Prop 98 that is affected by the general fund. If that is the case, which I think that honestly, I don't know if that may be a Supreme Court ruling or not. The California Supreme Court might have to rule on that. But at the same time, you get your money. So let's say now we've got the waiver. So we got waiver money coming in. That's a big bulk of the pot, huge bulk of the pot. And then, we get the progressive taxation. The billionaires, unfortunately, will have to pay their taxes. And they're probably going to go flee to Texas where they're not going to have power in the winter. And then they're going to get mad and they're going to come back to California because they're going to want it to be warm. They're going to feel some kind of way. We know that. And then, so then, now it's like, okay, well, we have the budget, we've got the money in here. So now what? So now, what I like about this is also kind of the transparency here. See, when your motive is not profit, you can be a little bit more transparent. What do you have to hide? Granted, government is government, but at the same time, so in AB 1400, it says that the CalCare budget should consist of the following components: an operating budget, which means the people who actually, your assistants, your people who are actually making CalCare run. So you have an operating budget. You have to have a capital expenditures budget, and then special projects budget. So special projects could be, going out into the community, doing community events, doing, screenings or something under CalCare, anything. I mean, anything could fall under special projects, but truthfully, I would hope that that's what special projects would probably mean. Program standard activities. So, getting enrollment and all that, getting people enrolled, the CalCare cards, all that stuff. Health professional education expenditures, and then administrative costs, and then prevention and public health activities. So that is what the CalCare budget, those 7 parts are what the CalCare budget will consist of. Don't ask me to go deeper than that, because the bill doesn't go deeper. Well, it doesn't go deeper than that in the budget, but it does say that the board shall allocate funds received among the components described in subdivisions B to the following. The operating budget allows for participating providers to meet the healthcare needs of the population. That's important. So when you say that, the healthcare needs of the population, CalCare will always be kind of at risk, and it will always be at risk of running out of money. And that depends on how well we take care of ourselves too, because other countries who have universal systems, yes, are having some strain because we've gotten unhealthy as a people. And so now that if I give you all the coverage you need, now let's go be healthier so that coverage lasts. Because if we continue on our unhealthy path, diabetes, dialysis is expensive as hell. Kidney transplants, all these things that are happening because we have just become unhealthy as a culture. Yeah, CalCare, the budget, it's going to continue to have to be increased because we have to continue to offset the high cost of care. Because, people are just really sick, but some of this can be avoided. So that's going to be like phase 2 or 3 after CalCare is passed, which is making overall California a healthier place, healthier people. And that's a preventative measure. That's preventative medicine. That's also a preventative budget. To make CalCare last for the masses and for the lifetime, we have to, make ourselves a little healthier. And that's okay, because we will, because I will stop stress eating M&Ms. I will stop stress eating M&Ms. Okay, and then a fair allocation of special projects budget to meet the purposes described in the section F, which is, payments to nonprofit or government entities that are health facilities, and so, this is where it also talks about health and safety code for construction or renovation of healthcare facilities, major equipment purchases. So if that rural health center really needs a CT machine, this is under that budget. Staffing in rural or medically underserved areas, under special projects here. To address the health disparities, including those based on race, ethnicity, national origin, primary language use, age, sex, disability, etc. So it's written here under special projects. Special projects is this key portion that when we say that we're going to provide equity, it's in the special projects portion of the bill. This is providing the equity. This is getting that rural healthcare center, that CT machine, or maybe access to mobile CT. This is getting, making sure that there are clinics in Compton. There's no more a health desert in certain areas of Los Angeles, or certain areas of Modesto or Fresno or Central Valley or up in the Bay. This is key right here. So it's written in paper. The words are there, the language is there for us to be able to know that, okay, you know what, you have it in a budget to be able to fund these areas that really need it, these underserved areas. And so, like I said, gonna have to hold them to it. But at the same time, it's there. It's not just as needed. It is written out that this is where this special projects money is supposed to go. Not to the CalCare Christmas party. Okay, we're going to get, we're going to up in Mr. Jim Wood up there and maybe some area in your district that needs a CAT scan machine, that maybe needs a clinic refurbing, or, they need better access to lab services. Right here, CalCare is going to help you out, okay? It's going to help out your district up there in District 2, very rural, very wooded, suffering from wildfires, think about all the asthmatic and respiratory problems going on up there right now. So I'm just saying, in the last 2 minutes, special projects is going to be where it's at. It's really special. And so, but then also a fair allocation to project standards or program standards, I'm sorry. And then a health professional education expenditures component is sufficient to meet the need for covered healthcare items and services. Operational budget capital expenditures shall be used for the construction or renovation of healthcare facilities, excluding congregate or segregated facilities for individuals with disabilities who receive long-term care services and supports under CalCare, and other capital expenditures. So this is supposed to be used for construction or renovation of healthcare facilities. So our facilities aren't just going to go to shit because it's a single payer program. That's another thing. People are like, oh, your hospitals are going to be terrible and dirty, and look at, Venezuela or whatever. No. Now, do I think that every hospital needs to look like a 5-star resort? I really kind of don't. I want them to be clean. I want them to be nice. But, all the aesthetic, like resorty hospital, that the resort thing that the hospitals have focused on now, it's like, is that really needed to make you feel better? Or is it just better that you have updated equipment and an updated bed, the sheets are clean and not tattered and torn? Like those are the things that when I'm sick, I don't care, because I'm like, you're still going to see my butt in the back of that gown. No budget is putting the back on the gowns. I'm sorry. The gowns will still show your butt. And on that, it is 7 p.m. people. We'll go a little bit more into the budget discussions, but CalCare will not put backs on the gowns. Your butt will still show when you're in the hospital. So, but that's okay, because you're going to get the care that you need with your butt.
That's what they call a complete coverage, is when your butt gets covered. Yeah.
Your actual butt is covered. The back of the gown is uncovered, okay? But your booty's covered. So you guys, thank you for joining us for another CalCare office hours. I really appreciate it. We will continue to go deeper and deeper into this to answer these nuanced questions as you guys bring them to us. So please feel free to come and join us with your questions. Elected officials, please feel free to come and join us too. I would love to see your guys' faces and answer questions that you may have as well. And we will talk.
Tell your friends about it.
And yes, tell your friends. If you guys tell your friends about CalCare, tell your friends what we're doing. It's important. This is huge. This is big.
Be here or be square.
Exactly. Square. Don't be square.
Thank you, right. Gina. You're amazing. And thank you, Paul, for setting this all up. So great job. Good to have Danette, Dennis, Stephanie, and Jeffrey with us too.
Yes, thank you guys for all your questions from the chat. I appreciate the good conversation. But like I said, next week and moving forward, I think we are going to be going a little deeper. Also, follow Healthcare for All Los Angeles, because we're going to be posting our events about our virtual text banks that we're going to be doing every Friday. This for Fridays for September from 6 to 8 p.m. So we would love to have you join. It's actually pretty fun. And so, we're going to be texting voters in all these key districts that we've been talking about with the Assembly. Like I said, this is the people's bill. We're building pressure from the bottom up. You guys have a great day and take care. Stay safe.
Bye-bye.
See you.